I'm going to move directly to this team activity as a group. We had you go through this list of procedures in an attempt to outline who in your neighborhood, that is in your county and adjacent counties, is doing these procedures, who's furnishing these services, what is their training, and any details you might have about the individual's training. So if it's a family physician doing C-sections, did they have a fellowship, or have they simply completed a 3 or 4 year family medicine residency? You may not know the answers to that for every one of these. And so what I thought I would do is first just ask you, what did you learn from doing this exercise about your own neighborhood that you think might be interesting to people from British Columbia to Selma, Alabama? And we'll just ask someone from your group, if you will, to be willing to speak up, or I'll call on people. I don't see any hands going up. How about Roseburg, Oregon?
Yeah, so thanks, Randy. All of that is trapped on my computer at CHI, and my access was disabled as we're switching employment. So I haven't shared this with the group. We haven't been able to go. So they're hearing this for the first time as you are. So Roseburg is a town of about 20,000, and we have a sole community hospital here, much larger than what you have there. But in our community, we've just reintroduced family medicine obstetrics, and we have one doc who does C-sections and another who is joining our practice. So we'll have 2 family docs who do C-sections. We do about 800 deliveries a year in our community. We also have another doc, family doc, who does almost primarily as his sole practice, upper and lower endoscopies. We also have all of the specialties, OB, and we have GI docs and so forth. So there's intense competition for the procedures. We are rural, but we are not isolated. We are right on the I-5 corridor between Vancouver, British Columbia, and Los Angeles, or even farther south. And so it's pretty easy for our patients to go up and down. We do not have family docs who are doing general surgery procedures such as appendectomy or hernias. We have family docs who are doing ultrasound. Interestingly, we don't have any family docs in the community doing vasectomy. We had a urologist, they took all of them, and that skill kind of atrophied over time. We're looking to reintroduce that into our community. But we just started a family medicine residency, and the group that's assembled here are some of my residents and some medical students who are looking to see how we might create a 4th year procedurally oriented fellowship.
Excellent, excellent. How about Silver City?
Yes, can you hear me? Hey, Randy.
Hi, I can hear you sort of.
Okay, I'll try to speak louder. I took my mask off just for you.
Excellent.
So we would love this kind of fellowship here. The problem is the numbers and the list of, I guess, description of the things that are going to be taken into account in a fellowship. The last one was maturity of the maturity of the resident and the preceptor. Like, how do you even gauge for that? So in our community, we do less deliveries. We have a total, including C-sections, of maybe 220, and our numbers have gone down over the years because we are rural, although we do cover 5 counties. So the problem with having a surgical fellowship for family medicine, I think, would be good because we'd be an assistant. I learned from the 4 surgeons that are in, and also the 2 OBs that do the C-sections. It's just getting the idea across that the competition is not there, it's a learning environment. And I think that in the past, when other family docs have tried to get their C-section privileges, it's always been kind of a political struggle for the numbers. But I think that fellowship, having involved all kinds of areas of surgery and the different procedures that were mentioned here on this list, I think that we do a fair number of those. It's just being the go-getter and getting the opportunity to do them. I think it would be a great idea in somewhere like Silver City, and I think it would do really well because it would always be somebody on call with one of our surgeons. And I told you, we have 4 surgeons right now. We're fortunate right now to have 4. So I think it's a great idea for those of us who are more rural, have to learn it all. Like, don't have the luxury of all the specialists. So when you learn family medicine with us, you're co-managing, you're managing things that normally you can send off to cardiology or to rheumatology. Although we have one cardiologist in town, we do a lot of co-management because he can't possibly see all our patients. So we get the full-fledged family medicine here. It's just the C-sections are limited, although you can go to deliveries with our OB in town, and he does deliveries. So I think it'd be a great idea. I think if we could formulate something to start one, I think our part of the state would be great because we're on the southwestern part of the state, which is very rural. So I think it's a great opportunity. Thank you.
So what I'm hearing you say is that your family physicians do many of these procedures, but so do your general surgeons, your obstetricians, et cetera. And so it's hard for any one of you to have a significant volume.
Yeah.
Unless you work together, which
Exactly.
would be the way to do it. Yeah, yeah. So do you have any family physicians who do C-sections? That canary in the coal mine thing?
We have no family physicians here who do C-sections who are privileged. Dr. Nelson used to have them, but he hasn't done them in over 10 years, so he's not credentialed to do them. And they would require him to do the 5, and he just won't do them. He doesn't have, I guess, the time, or doesn't want to do OB anymore. So okay. I can't. You talk to him about that if you want. That would be great. But
all right.
It would the continuity with our patients. But like I said, we had one other faculty member that left our residency program, and she's in Texas now. And she was fellowship trained to do C-sections, and she just never got the support to do her C-sections at our hospital. So she spent 5 years here not doing any C-sections, and then went back to Texas, rural Texas, and now she's having to beef up her skills again, but she's finally doing them again. But I feel like there's a lot of politics in small communities, and like the numbers, it's a competition for the numbers. No one's going to give them up. No one's going to give them up. So we have to figure out a way to work together.
Excellent. How about Selma, Alabama? What's it look like in Selma? Do you have Selma online? Maybe not.
I'm not sure they were able to join us today.
Okay. All right.
I'm just one of the residents here from Selma. We do have general surgeons that partake in the actually all of our colonoscopies and endoscopies in general, and are performing all of the general and some of the more advanced surgeries as well. But the vast majority of the obstetrics and gynecological procedures are completed by the board certified OB-GYNs, with our assistants as residents when we're not in the clinic or partaking in any other family medicine specific ventures. But we do have a fellowship here, a hospitalist fellowship to be specific, but I guess I'll defer to our PD and others in regard to whether or not we would be able to sustain a fellowship in regard to some of these procedures and such.
So what I'm hearing is that you have sufficient board certified specialties to address all of these procedures, and as residents, you're able to participate co-manage, assist, et cetera. But in terms of any faculty, family medicine faculty to model procedural work, not so much.
Seems to be fairly accurate. Our program director did actually complete a fellowship in OB-GYN as well after her family medicine residency. Though I think we're still in the process of working on securing that level of exposure. She's the only one that would be able to help us out, and she's already stretched fairly thin with the other obligations, including being a hospitalist. I think once we get a little bit more faculty support, we might be able to incorporate some of those OB procedures, and that would be a good route to look at in the future.
Well, it's really interesting. The American Board of Family Medicine has recently surveyed family physicians who graduated within the last 3 years and have found that although many people intended to do obstetrical work or even are fellowship trained to do so, doing it in practice is difficult because of all kinds of local factors, and we've heard about those. Excellent.
I will add just briefly that I think that one of my favorite days of residency thus far has been my also training out in Centerville, Alabama, as well, where we learned a variety of obstetric and gynecological emergencies, and had the opportunity to practice these procedures and maneuvers on mannequins and have some testing and such. So it's certainly a skill I'd like to continue to develop, and I think also training was quite helpful in that.
Excellent. Well, let me just say, are any of you in a rural area where individuals have to travel quite a ways to acquire these services? We've heard from Joel and David in Iowa, but in any of your other situations, including those of you in British Columbia, how far do people have to go for some of the procedures that were listed on this list? Let me just ask to all of these services, and I'll go back up to the list again. Within a half hour.
Sorry, Randy, your video kind of cut out there. I don't think we heard the whole question that you just asked.
Oh, I'm sorry. So the question was, is there anything on this list that that patients in your neighborhood have to travel more than 30 minutes to acquire?
So Ryan here up in Northern Canada. Just maybe, I think, some other Canadian colleagues too, depending on where each of us lives, the geography is a bit unique, but Inuvik itself, where I live, is about 3,200 people. So we're the hospital that has the surgical, the operating room and the surgical services run by family physicians, anesthetists, and ESS like myself. But our catchment includes a lot of more rural and remote Indigenous communities. And the furthest community, I don't know the distance would be, but you're looking at about an hour-and-a-half flight in a small twin-prop aircraft. That's the only way to access that community. So if there's a surgical emergency up there, and we have to then triage it as something that we can handle here locally with our skill set, or do they have to go on to our referral center? So for us, geography is a big challenge. So, somebody up there has to come to town in Inuvik at about 36 weeks for confinement for anything obstetrical. But if you have a different surgical emergency, you're looking at probably 2 to 3 hours minimum from medevac to getting them to our operating room.
So in looking at the training of the physicians in your setting for these kind who do any or all of these?
I'm sorry, your video cut out again, Randy. I didn't hear the question.
Which of these surgical skills are required of family physicians, and how have they trained?
So our family physicians who have enhanced surgical skills would perform all of these procedures. And those who work here, either we trained in the program in Saskatchewan that Dave and Joel modeled their program on, or they're older South African physicians who came to Canada, 30 years ago, who came here with that skill set already. So in Canada, there's really only the one site right now that is training us to do this full spectrum.
Excellent. And in Canada, family medicine residency is 2 years, maybe going to 3. Tell me more.
Yeah, the family medicine residency is 2 years in Canada. And there's kind of two streams. There's the family medicine if you're going to be practicing in a more urban center. But if you think or intend to practice rurally, then you can have more rurally focused rotations. So you'd be finishing your family medicine residency with sort of being comfortable in an emergency room with the usual emergency procedures, doing obstetrics, inpatient care, palliative care, home care, regular family practice, the whole spectrum of what I would call rural generalism. And then the surgical skills such as on this list would be a separate set of skills, except for vasectomy and ultrasound. Everything else would be a separate set of skills that you would have to acquire through a 3rd year of residency, such as the one in Saskatchewan.
Excellent. And that is a 1-year training program.
That's correct.
Excellent. So I guess my question to the group, and maybe I'm preaching to the choir, but is this a reasonable thing for family medicine in the United States to pursue? Should there be more fellowship programs like that one in Corydon?
Hi, Randy. Brandon in Silver City as well. Absolutely. I'm a huge fan of this type of training for family medicine physicians. Currently in Silver City, we're kind of undergoing an interesting transition. So we have a county-owned hospital that was previously about 60 beds. And so we do have general surgery that is able to maintain their own private practice. We have OBs that have their own private practice, but we're moving to the critical access, which is going to drastically cut our number of beds, which in turn is going to, I think, make it very difficult for the OBs to be able to stand alone and for the surgeons to be able to stand alone. And without a family medicine physician or someone who's able to do sort of the whole spectrum of everything, I think it's going to be a challenge. It's going to be really interesting to see what happens to our hospital.
Excellent. Yeah, sometimes external circumstances in your community dictate what happens. Other thoughts?
The group over here in Roseburg, the residents and students would like to give their opinions about the importance of this training. Who's going to speak? Anyone?
I think we're all just very excited about the opportunity.
Yeah, I'm Gabby. I'm one of the new interns in family medicine, and I did a year of general surgery training before this, and I want to practice on the Oregon coast ultimately, where people would have to travel hours to get care and surgical care. And so I hope that we can develop this integrated into our residency and maybe even a fellowship in Roseburg, Oregon in a couple of years. Yeah, thank you guys so much for this information.
Excellent. Anyone else there in Roseburg?
Any of the medical students want to chip in?
Yeah, it'd be great to hear from a medical student.
Yeah.
So hi, this is Jessica. I'm a 4th year medical student. I grew up in the eastern side of the state, La Grande, Oregon, which is a critical access hospital. And growing up in that community, it was very common for patients to actually forego treatment because they did not want to travel the 2+ hours in either direction over the mountains to get to care. So having family med physicians in that community that had this excess skill set would have been huge. We had, I think, 3 OB physicians. They were all associated with the hospital. So, I mean, in the summer when there were multiple babies being born, it was an issue. There were no other OBs there to help. So I think in those smaller communities that are particularly prevalent in the eastern side of Oregon, this would be a significant skill set to have. And me wanting to go into rural family medicine, this would be phenomenal to have to take back to my community.
Outstanding. Excellent. Well, I'm going to just open it up in the next 4 minutes or so. Any other questions, comments? Anybody who wants to say anything, you're welcome to do so.
I think I'll just put in the chat to everybody a resource. We have collected all of our information on ESS training, as well as our modular training program and all the research we have found on family doctors doing procedures in small areas on one website. It's our Society for Rural Practitioners of Canada website. I'm gonna stick it here. It's a pretty easy link to go to. So if anybody's interested in looking at more of what we've done in Canada, in terms of the and like it almost follows the history of us putting the program together and everything. You can go to that link and there's a whole bunch of stuff on there.
Excellent. Thank you so much for that link. And Dr. Iglesias, do you have any comments?
I think what Joel and David are doing is just outstanding. The home truth in Canada is that as a nation, we are pretty much committed to rural maternity care, to the value of delivering as close to home as possible, especially for the Indigenous communities. But we know from the evidence that care and outcomes become chaotic when you have to travel. And what that does is that's the wellspring from which everything else that we've done comes from. You can't do, it doesn't seem that you can do sustainable maternity care in today's age without a local C-section program. So if you really believe in maternity care, then you have to be able to do the cesarean sections. And we also know, and the evidence for this is more recent, that you can't do a standalone cesarean section program. You just can't keep an OR busy and staff trained and on call, et cetera. And so you need a rural surgical program. So there's a direct link from sustainable rural maternity care close to home to a functioning, comprehensive surgical program in rural Canada. And once we were able to build that intellectual and evidence structure, the support for what we were doing accelerated. And it's still our foundation. There are all kinds of different size communities and different ways to do it, but it all comes down to the same thing when we're asked why, because we want women to deliver close to home. So I think I would just, in the few minutes I was given there, would sort of offer that lens, if you like, as to what and why we tried to do what we did in Canada.
That's excellent. And I really appreciate the pioneering work that is now accessible to the rest of us, the evidence that this can actually be done and be done well. And I really do want to thank Joel and David for presenting to us today. Do you guys, David and Joel, do you have any comments that you would like to make?
Well, first, I was very grateful.
You're going to have to speak into the microphone.
So the way you worded that question, I mean, you could have just said, okay, does everybody think they're crazy doing this? So, but I appreciate the comment from Roseburg. I think any of us in a rural community appreciate the desire for people to receive care close to home, whether it's maternity care, endoscopy, procedural, hospitalizations, reliable ER. And I don't think that's going to change. So, and our program was driven by necessity. We're older physicians. We won't be around a lot longer. We're trying to establish a model that will recreate the doctors so that they have the skills to do what needs to be done, where it needs to be done. And there's a little bit of a crisis sense to that. There was nobody, some of why we did this, there was nobody coming to help. That's where I was for I'm 32 years now here, and you're always looking for that doctor that's trained like you are, and it's going to come and be with you, and your life's going to be better. And it became obvious that it's a lack of training opportunities. Nobody's trained to do this. So we started it.